also do send in, um, in mental health as well. So how do we classify hyponatremia? So it depends on the severity. So mild is usually if it's between 130 to 135 millimoles per liter. Moderate would be between 125 to 129 millimoles per liter, and severe is less than 125. There is a reason why it's classified in this way, because severity will determine your management. So for mild patients, you may not need to treat them as much. Moderate, you may need to tweak a few things. Severe hyponatremia tend to be admitted to hospital and need slightly more aggressive treatment. And again, it can also be classified in terms of its rate of onset. So if it's acute, less than 48 hours, you may need to act on a lot sooner, especially if it's dropping by quite a lot. If it's chronic, as in like it's taken a few days, or at least more than 48 hours to slowly drop below 135, then your management may change as well. Of course, its causes can be multifactorial. There's so many different ways you can get hyponatremia, and we'll explain in the next few slides. And again, like I said, management depends on what the cause of the hyponatremia is, which we'll explain in coming slides, and the severity of the hyponatremia, whether it's mild, moderate, severe. So some of the causes. So causes can be broken down into essentially the fluid status. So you can get hypovolemic hyponatremia, euvolemic, and hypervolemic. So essentially, hypovolemic hyponatremia is, if there's volume in the fluid status, that could be, dehydration can cause hyponatremia. So if they've got severe GI upset like diarrhea, vomiting, medication, like for example, thiazide diuretics like bendraflumethiazide, or like loop diuretics can also cause hyponatremia, for example, furosemide. Of course, endocrinological conditions can do the same, as in Addison's, where they've got reduced production of steroid, and in that way they sort of lose, or because of particular area of the adrenal gland not working, so they've started to lose salt and keep potassium in. Excessive sweating, excessive exercise can, because you're losing salt or sodium through sweat. Third space losses, for example, if you've got bowel obstructive pancreatitis and sepsis, that can also cause intracellular, extracellular changes where you get hyponatremia. And of course, burns patients, it has to be quite extensive actually. You can get skin, so sodium loss through transdermally. And one of the rarest causes is cerebral salt wasting. That's usually if they've had cerebral hemorrhage or pituitary apoplexy. Essentially, pituitary apoplexy is if there's a tumor there that's caused the pituitary gland itself to die, as either temporarily or permanently. That can cause a reduction in sodium as well. Hypovolemic hyponatremia is if they've got excess fluid overload. In certain conditions like so it's all pretty much usually dilutional because they've got excess fluid in the body. So congestive heart failure can cause hyponatremia, liver failure because, for example, cirrhosis because of the reduced albumin production, or also can cause fluid retention and can cause hyponatremia. And then, of course, if they've got kidney disease, for example, AKI, CKD, or nephrotic syndrome, again, can cause fluid retention and cause dilutional change in sodium. If there's no change in the body fluid status, that's mostly caused by medications. So, in fact, for example, there's increased risk with SSRIs like citalopram compared to other psychotics can cause hyponatremia like haloperidol. And of course, like mood stabilizers like sodium-valproate and lamotrigine, carbamazepine, can cause hyponatremia. So it is also, you do tend to see it as well in the mental health, because I think there was a patient on Fraser who's had problems with hyponatremia. I think Gabby will probably know that patient very well and had to check his sodium over the weekend or on calls. So yeah, essentially, so tweaking the medications can help, but we'll explain it in the coming slides. ACE inhibitors, of course, proton pump inhibitors like omeprazole can cause and of course SIADH, this is when you've got significant amount of ADH being produced, either secondary to malignancy, infection, meningitis can cause it, medication, autoimmune. So the management of SIADH depends on the cause of the SIADH, and then that will in turn, once you treat that provoking factor, you'll be able to correct the hyponatremia. Of course, if you've got adrenal insufficiency, if the pituitary gland isn't producing the hormones, you can get hyponatremia. Of course, severe hypothyroidism. It has to be extremely severe for hypothyroidism to cause hyponatremia. And I'll pass it on to my colleague.
Just wondering if anyone has any questions. Hi, this is Sadia. All right, so just moving on. Hyponatremia symptoms are very well known. So there are general symptoms such as headaches, nausea, vomiting, poor appetite, lethargy, fatigue. These are just general symptoms, muscle cramps, confusion. But in severe hyponatremia, may experience seizures, neurological symptoms. These symptoms obviously will be more notable in chronically ill patients, the elderly, etc. So in terms of the signs of hyponatremia, it manifests primarily as neurological because of the osmotic shift in water. We're shifting it to be the cerebral cells and causing cerebral edema. So you'll notice like low GCS, disorientation, confusion, poor concentration, poor memory. You might notice this when you're doing a mental state exam. Altered personality, irritability, restlessness, anger even. When there's a rapid drop in the sodium levels, that can cause severe cerebral edema causing brain separation. This is acute hyponatremia. So this is an emergency, so it causes respiratory arrest and death. Other signs we can divide them into the cause. So depending on the fluid levels, in hypovolemia, there are signs of hypovolemia, so dry mucous membranes, reduced skin turgor, reduced urine output, sunken eyes, low BP, tachycardia, etc. In hypervolemia, it also depends on, so you'll notice cramps on auscultation, raised JVP, peripheral edema, added heart sounds. And so the causes of hypervolemia would be like liver cirrhosis, nephrotic syndrome, congestive heart failure. In terms of making the diagnosis, it all depends on taking the clinical presentation, taking a detailed history, assessing the symptoms, reviewing the medications, and reviewing the fluid status, so the urine output, fluid chart, assessing if these are acute symptoms, if the presentation is acute or chronic, and then with the aid of all these tests, you can do a lot of blood tests. You can also do the serum osmolality, urine sodium levels, to see if this is obviously pseudo hyponatremia or true hyponatremia, and imaging as well to remove any suspicion if there's like a cardiac issue or liver issue or renal issue.
So the next part is usually, I think it can be a bit confusing in terms of like what the heck are we talking about when we mean osmolality, and then why do we look at urinary sodium, urinary serum osmolality compared to urinary osmolality? It'll make sense in the next couple of slides, I hope. So it can be confusing, and people can get a bit lost, because I remember when this patient on phrase, I did get a bit confused about what we were actually looking at when we got the results for the osmolality. So it's essentially, so the first thing you want to look at is serum osmolality. So essentially, this is to see what the concentration of the sodium level of, so in particular in this case, sodium is in serum per kilogram. So it'll give you a good idea whether this is a hypertonic solution, whether hypertonic serum is a hypotonic or normal. So it depends on the milliosmol per kilogram value that you get when you do the serum osmolality. So if it's over 295, then that means you've got very high osmolality. It's quite a hypertonic hyponatremia. This isn't true hyponatremia. It can be secondary to, for example, if you've got type 2 diabetes, you can get a hypertonic serum. And or if you're given a hypertonic solution like mannitol, that can also affect the result and give you a higher than normal osmolality. If it's anything between 275 and 295 milliosmoles per kilogram, that's usually considered a normal osmolality. And if you've got hyponatremia together with it, then it's pseudohyponatremia, and the conditions like multiple myeloma can cause it, as well as like if they've got high triglycerides or very high lipid profile. Anything under 275 is low osmolality, so you've got low solute in the serum, and that usually indicates, okay, this is your true hyponatremia. So this is the value. So if you were going to take something from this in terms of serum osmolality, this is the value to look for. If it's less than 275 milliosmoles per kilogram and they've got hyponatremia, then you would want to look for the cause of this hyponatremia. Then the second part is usually it's serum osmolality, urine osmolality, urinary sodium. Those three things are what you look for when you investigate the cause of hyponatremia. So again, essentially, you take a urine sample, check the osmolality to see whether it's a dilute urine or concentrated urine, and then usually it sort of tells you about the level of the ADH activity, whether ADH is working or not. So if it's less than or equal to 100 milliosmoles per kilogram for urine osmolality, then it's a dilute urine, and this means that ADH is not working, and you need to. Then it makes you think, why is ADH not working? Is it because of polydipsia? Is the patient drinking a lot more than they should be? And then you would investigate the cause of polydipsia, whether it's sarcogenic polydipsia, where you see that sarcogenic polydipsia is usually a diagnosis of exclusion, because you want to rule out whether ADH isn't being produced in the brain or ADH isn't being responded to by the kidneys. So that's usually diabetes insipidus, or are they not drinking enough solutes? So it's not why the urine is quite dilute. And if it's greater than 100, this is what you're looking for. Then that means that the urine is concentrated. So are they? What's causing this is, we know ADH is working because it's an antidiuresis. It's in the name. It's stopping you from urinating. So it's keeping fluid in, and the urine is concentrated. So you want to look for causes of the hyponatremia. So this is so again, another thing to take from this slide is this value. So if it's more than 100 milliosmoles per kilogram and of urine osmolality, it's a concentrated urine, and then you need to look for the cause of the hyponatremia. So usually in conjunction with the urinary sodium, which they'll show, it kind of helps you differentiate what you think the cause of the hyponatremia is. So for example, if you're looking, if you go on the right hand side, where if it's more than 100 milliosmoles per kilogram of urine osmolality, it's a concentrated urine, then you want to look at the amount of sodium in the urine sample itself. So if you've got a lot of sodium in the urine, if it's more than 30, you always want to make sure that it's not secondary to medication. For example, diuretics and ACE inhibitors being the most common culprits, and that would be your primary cause. If you don't think it is that, then you would think, why is this happening? Is it because of SIADH, where you've got ADH being secreted in significant amounts and it's unsuppressible? Are they vomiting? Is it because they've got addisons, because they're losing salt? Or is it cerebral salt wasting, where they've got subarachnoid hemorrhages, or pituitary apoplexy going on? If the urine sodium is less than 30, so it's concentrated sample, but you don't have a lot of sodium, then that means so for example, where salt goes, water follows, essentially. So if you're keeping a lot of the sodium in, then is it because of fluid retention? And is it, then you start looking for causes like heart failure, cirrhosis, nephrotic syndrome, high blood pressure that's causing issues with the kidneys and the heart, hypovolemic because it's protein, low protein will cause, shifts in oncotic pressures, or is it because of pancreatitis, bowel obstruction, things like that? So you want to look for the other causes. So I hope this sort of breaks it. So essentially, you look at the serum osmolality. Again, if we were to go back, so anything less than 275 is a true hyponatremia. Right now, let's go and check the urine osmolality. Okay, anything more than 100 for the urine osmolality, okay, need to look for the hyponatremia. Now let's use this urine sodium in conjunction with that to find out why this is, if there's too much salt in the urine or too little salt, what could be causing it. I hope this makes sense and it helps. Sorry about the memes, I tried to make it a bit lighthearted. So yeah, I think just as long as you remember those three things and when you're trying to look for the cause of hyponatremia, it'll make things a lot easier when looking for the causes. I'll pass it on again.
Just wondering if anyone has any questions again.
That's always a good sign. Or maybe saving it for later.
So in terms of management, we just have a very mild hyponatremia and asymptomatic patients rarely requires any treatment. If the patient is symptomatic and is presenting with severe hyponatremia less than 125 or it's acute onset less than 48 hours, this definitely requires admission. If you suspect an endocrinological problem, for example, adrenal deficiency, pituitary tumor, hypothyroidism, etc., you can involve the relevant team and discuss that with them or refer them to the endocrinology. Or if you suspect malignancy, you can obviously do the two-way referral. Oftentimes you have to involve other teams like the gastro-cardio team, because in hypovolemic hyponatremia, sometimes it's congestive heart failure, nephrotic syndrome, liver cirrhosis, portal hypertension, etc. So in primary care, in a GP setting, most of the times it's asymptomatic and mild hyponatremia that gets picked up. And in these cases, you can do the wait and see approach where you just observe the patient, repeat the sodium levels in about 2 weeks, just to see that it's not rapidly dropping. If you obviously have to take into context the presentation, the patient's symptoms, history, background, medications, etc. If there's anything in its medication that could be causing it, you might have to stop it or discuss with the relevant team. If you can't stop the medication and you need to keep this patient on that medication, you might have to involve the necessary team to observe as well and discuss with them. So you can stop or monitor them on that medication and just review. If it remains low after stopping medication, discuss with endocrinology. Also look for other underlying causes. So on the ward, that management would be in secondary care. We'll talk about this.
Yeah, sure. So in hospital settings, so again, it depends on how quickly the patient is getting, how quickly the hyponatremia is developing. So like acute onset, rapid or quite rapid deterioration in the sodium levels, or also symptoms if they're coming in, they've had a fit and you've checked their sodium levels and it's quite dangerously low, then they definitely need treatment. And of course the volume status, where if they're severely dehydrated, those patients need to be treated quite soon. So again, like acute hyponatremia, so if it's very severe hyponatremia, then you would treat with a hypertonic saline. So for example, a year ago, I had a patient who came in with a thunderclap headache, photophobia. Initially, we thought maybe he's had subarachnoid hemorrhage. We did a CT, which showed a pituitary microadenoma, like a large tumor. But his sodium levels, everything were fine. His sodium levels was around 138, 140, so within normal range. But as his headache improved, his sodium levels started to drop, and they could drop quite dangerously low, and it dropped to 111. He became a bit drowsy, but he ended up having pituitary apoplexy. He had a bleed into that tumor that effectively killed off his pituitary gland, and then he needed to be treated with. I remember staying till like 7, 8 o'clock in the evening, treating him, and then with hypertonic saline, which is usually 3% or 5% or 6%, I believe as well, for normal saline, to try and bring up the sodium levels, to stop him from having a fatal complication of his hyponatremia. If it's mild or moderate, usually just try to treat the underlying cause. If it's, if there's an endocrinology cause, if there's any infection, which can cause, which can lead to SIDH, things like that, you would want to treat. If they're on a medication that's causing it, then you try and stop it. So if there are any diuretics or any medication that's provoking it, you stop it. And this would be true for all types of hyponatremia that you're treating in the hospital. So I put it here as mild, moderate, but even severe hyponatremia would stop any medication that they're on that may be causing, unless it's a medication that you can't stop suddenly, then you need to get specialists involved. Chronic hyponatremia, you usually try and stop any medication that they're on, maybe treat the underlying cause, but you're not too aggressive with the management, unless they've always had a sodium level 125 to 26 for a year, and then suddenly now it's at 118, 119. Then you probably may want to get involved. But in these patients, you just want to keep an eye, stop any unnecessary extra fluid that they may be having. And hypovolemia, so for example, if they've got heart failure or liver failure, then you try and treat the underlying cause of kidney failure. For example, in heart failure, you'd fluid restrict them. Sometimes you could still give IV diuretic to try and offload that. That may make hyponatremia slightly worse, but then again, trying to get cardiologists or specialists involved. For example, if in renal failure, you may want to do a dialysis in these patients to try and get some of this excess fluid, and of course, involve the hepatologists as well in liver disease. If the hyponatremia is because of hypovolemia, where they're severely dehydrated, again, you try to treat the cause of these dehydration. Also, you want to give them IV fluids. Normally, it's normal, say 9.9%. SIDH. So usually people get confused between SIDH and cerebral salt wasting. Sometimes, so fluid restriction, if you fluid restrict and the sodium starts to improve, then you've got SIDH. In cerebral salt wasting, you won't get that. Even the cerebral salt wasting is rare. But when I was treating that gentleman with the pituitary apoplexy, at one point we were thinking, is this because of SIDH that he's on top of his pituitary apoplexy, or does he have the rare cerebral salt wasting? And when we fluid restricted him, it did not improve. So we knew it was cerebral salt wasting. So again, SIDH, you want to find out the cause of it. Like you want to do a chest X-ray, you want to do CTs, MRIs, maybe malignancy that could be causing it. And of course, you want to do the other investigations, the osmolality system, and the urinary sodium. Tolvaptan is used. Tolvaptan is usually a vasopressin antagonist. Again, it essentially just stops ADH, but that you would only use it in an IT setting or a very specialist setting. So again, like with complications, it's sort of elderly is usually at risk of fall because they become lethargic, become a bit confused, drowsy. So their risk of falls, they can get fractures. Memory concentration problems can sometimes be long-lasting, sometimes can be temporary. Of course, sudden hyponatremia, like Abdi was mentioning, can lead to severe edema, and that can cause brain segment herniations, comacies, and these usually can be very fatal. And the other thing is you don't want to correct it too quickly, otherwise you get a neurological complication called central pontine myelomyelitis. Essentially, this usually happens a few days after you've corrected too quickly, and then this patient ends up becoming quadriplegic. They have difficulty with the swallowing, difficulty with the speech, difficulty, like the mood is all over the place. So in these patients, a third of them will recover from the central pontine myelomyelitis. A third of them will have some sort of permanent neurological damage, and then a third of them will sadly pass away from it. So it's just to be careful. You don't want to correct it too quickly, otherwise you'll have this complication. So yeah, I think that's pretty much our presentation. I hope it made sense. I do apologize if we rushed it. Of course, we're open to any questions. Thank you for listening.
Thank you. I've got a question, if that's okay. So I guess my question about hyponatremia is how much do we need to worry about it in the acute setting? Because I know that sometimes some psychiatric symptoms, sort of change in behaviour or odd behaviour, can sometimes be a symptom of hyponatremia. But I'm just curious to know how common that is. So, for example, in the past, recently, I've been asked to do a mental health assessment on someone, an elderly lady, who hasn't got a history of hyponatremia. The last one in the system, her sodium was normal maybe a few years back. But on the day of the assessment, her sodium was 124, I want to say. And A&E didn't feel that a full assessment was required and just said that, she's fit for assessment, but they hadn't really done any sort of further investigations into that. And I'm just curious to think, is that something that, if the level of under 135 is hyponatremia, at what point do we need to worry? Because the A&E doctor was essentially telling me that if he saw that patient, he would discharge them and ask the GP to repeat the sodium and do the other investigations as an outpatient, and that it wasn't sort of acutely important. But I just wondered what your thoughts were on it, or whether you had any advice.
I think 144, I think that's brave to send someone home with a sodium level of 124, especially if the sodium level was normal a few years back and now they're presenting this odd behavior in terms of the odd personality change. I think it was probably the wrong thing to do to say, oh yeah, I'll just discharge 124. But then if we don't know how quickly that sodium dropped and what's causing it, is she not eating or drinking? Does she have GI upset? Is there something causing it? So I think in that case, I probably would have asked the A&E team to admit her, because we're not sure what could be, because this could be symptomatic hyponatremia. I think essentially for our psychosis or any change in personality, or we first need to rule out an organic cause, and we do have here an electrolyte disturbance. And most patients, the hyponatremia is asymptomatic, but then there's still patients who are symptomatic, and then in her case, she may well be one of those. And I think it's important to rule out an organic cause, and and repeat that sample again. If it stays the same after treatment or investigations, there's nothing to explain that hyponatremia, then you could argue, say, okay, fair enough, maybe there's a mental health reason why she's presenting the way she has.
And is poor oral intake a common cause for hyponatremia?
Elderly, I would say so, because dehydration is quite common in elderly patients. Yeah.
But would you see the renal function? Would that show that someone was dry or not necessarily?
Sometimes, if the sodium level is low, but then eGFR looks fine, but it's still it's dehydration. They can still be dehydrated. They may still have some clinical signs of dehydration, even if eGFR is normal. But you've got the sodium level to back you up and say, actually, no, this is quite low, and this is in the severe hyponatremia. In a nice guidelines, it says to investigate and treat. And this shouldn't be just, oh yeah, this is fine, I wouldn't do anything about it, this is all.
Yeah, I guess when you've worked in GP practices, or when GPs work, if they requested bloods for a patient sort of as an outpatient, and then those results came back when you were checking it, is that the kind of thing that could it be managed as can it be managed as a hyponatremia, or should we always be sort of, even say, for example, duty doctors, if we plug patients in and we're seeing a really low sodium, should we be sort of speaking to A&E at that point?
Yeah, I think it's just taking context and speaking to the patient and see how, or collateral history results, finding out what the patient. So for example, if I saw this in a GP setting, I'd ring the patient up and find out what's been going on over the last few days, how they're feeling, if they've got any symptoms. If I feel like that they're okay and there's nothing, there's no risk at the moment, and it's just like an incidental finding and they're asymptomatic, well, I'll probably repeat it in a day or two's time, make sure that it's not dropping any lower. Safety net down. And review the medications. I think as a teacher doctor, if we saw that, then it's the same thing. Just ask for those questions, see how they've been, what medication they're on, and if we think that they are exhibiting some symptoms that would be, that would explain the hyponatremia, then we could discuss with the med-reg on call and see what their advice. Because usually they will come under them.
Yeah.
And I feel like the medregs or the medical team on call will give a better advice than as opposed to A&E, because A&E, I think they're quite trigger happy to discharge patients, and sometimes I feel like it can be a bit dangerous.
Okay, thank you. That's really helpful.
Thanks. Very good question.
Because it really gets tricky with elderly patients. You don't know if there's something because of a mental health condition or if it's a symptomatic hyponatremia. Really tricky.
Any other questions? It does. Malalti bit makes sense because that's the bit I was like worried about.
Yes, it did, Mo. It's actually really helpful. Thank you.
Oh.
Yes, I just want to maybe provoke a further discussion.
Well, ladies and gentlemen, that was Hyponatremia presentation, and thank you for your time.